Hello and welcome to my audio medical basics to listen to when you do not have the free time or free hands to hold a book. If you like, please don't forget to like, share, and subscribe. Today I will be reading another case from my Case Files book collection by Lang McGraw-Hill. May I remind you that my videos are meant for quick exam revision or case preparations. They are not for immediate application and patient care. Actual update by a physically present doctor is always recommended before you exam and treat actual patients. So this is for pre-exam revision and for case preparations, case presentations. But please update your information, ask your doctors, and read books before actually treating patients. Thank you so much. Today, we'll be continuing. We'll take our third case. It's about the hypertensive emergencies and urgencies. In this case, hypertensive encephalopathy and pheochromocytoma. So let's begin. A 39-year-old man recently diagnosed with hypertension is now in the emergency room in an acute confusional state and with critically elevated blood pressures. He has been having episodes of palpitations, headaches, and lightheadedness. His medication was recently changed from clonidine to metoprolol. His examination is significant for dilated pupils, papilledema, and bounding peripheral pulses. The urine drug screen is negative, the CT scan of the head is normal, and the CSF studies show no evidence of hemorrhage or infection. So, the questions were, what is the most likely diagnosis? As we established, hypertensive encephalopathy. The possible etiology is pheochromocytoma. So what is the next step in this patient? It is to admit to the intensive care unit, immediately lower blood pressure with a parenteral agent, and closely monitor arterial pressure. So the objectives in this case is to learn the definition and management of hypertensive emergencies and urgencies, to understand the relationship between systemic blood pressure and cerebral blood flow, and to know how to diagnose and medically treat a patient with a pheochromocytoma. So, considerations. This is a relatively young man with severely elevated blood pressures who presents with altered mental status. Use of illicit drugs such as cocaine and amphetamines must be considered, but this patient's drug screen was negative in this case. Hypertensive encephalopathy, a symptom complex of severely elevated blood pressures, confusion, increased intracranial pressure, and or seizures, is a diagnosis of exclusion. So hypertensive encephalopathy is a diagnosis of exclusion. It has a symptom complex of severely elevated blood pressures, confusion, increased intracranial pressure, and or seizures. So, as a diagnosis of exclusion, it means other causes for the patient's acute mental decline, such as stroke, subarachnoid hemorrhage, meningitis, or mass lesions, must be ruled out. So, other causes for the patient's mental decline should be excluded. Decline or decline, you tell me. Knowing the specific etiology of the patient's hypertension is not necessary to treat his encephalopathy. Urgent blood pressure lowering is indicated, however, it is not necessary and may be harmful to normalize the blood pressure too quickly because it may cause cerebral hypoperfusion. Parenteral medications should be used to lower the diastolic blood pressure to 100 210 millimeters mercury. The patient has tachycardia, hypertension, diaphoresis, dilated pupils, and a light tremor. All signs of hyperadrenergic state. Pheochromocytoma must be considered as a possible underlying etiology of this hypertension. His anti-hypertensive medication changes may also be contributory, perhaps a clonidine rebound. So, definitions. MEN 2A, which is multiple endocrine neoplasia syndrome. Multiple endocrine neoplasia syndrome, which can occur in families. Type 2A includes pheochromocytoma, medullary thyroid cancer, and hyperparathyroidism. So, multiple endocrine neoplasia syndromes, type 2A, can occur in families, and it includes pheochromocytoma, medullary thyroid cancer, and hyperparathyroidism. And multiple endocrine neoplasia type 2B includes it's characterized by pheochromocytoma, medullary thyroid cancer, and mucosal neuromas. Clinical approach. Hypertensive crises are critical elevations in blood pressure, which usually are classified as either hypertensive emergencies or urgencies. The presence of acute end organ damage constitutes a hypertensive emergency, whereas the absence of such complications is considered hypertensive urgency. So, the presence of acute end organ damage, hypertensive emergency. If there is no acute end organ damage, it is hypertensive urgency. Examples of acute end organ damage include hypertensive encephalopathy, myocardial ischemia, or infarction associated with markedly elevated blood pressure. Aortic dissection and pulmonary edema secondary to acute left ventricular failure. So examples of acute end organ damage are hypertensive encephalopathy, myocardial ischemia or infarction associated with markedly elevated blood pressure, aortic dissection, and pulmonary edema secondary to actual left ventricular failure. Do I say a lot? Well, in my language it means coma. Hypertensive emergencies require immediate reduction in blood pressure over a few hours, typically with intravenous medications and close monitoring in an intensive care unit. Hypertensive urgencies also require prompt medical attention, but the blood pressure can be lowered over 1 to 2 days and can be monitored in the outpatient setting for patients with reliable follow-up. Hypertensive crises are uncommon but occur most often in patients with an established history of so-called essential hypertension. That is hypertension without an apparent underlying cause. So, hypertensive crises are uncommon but occur most often in patients with essential hypertension. A crisis may be precipitated by use of sympathomimetic agent, such as cocaine, or by conditions that produce excess sympathetic discharge, such as clonidine withdrawal. Hypertensive crises also result from underlying diseases that cause hypertension, such as renovascular disease, example, renal artery stenosis, and renal parenchymal disease, example, glomerulonephritis, and pheochromocytoma. So, hypertensive crises also result from underlying diseases that cause hypertension, such as renovascular disease, renal parenchymal disease, and pheochromocytoma. Although the pathophysiology is not completely understood, Abrupt rises in vascular resistance are met with endothelial compensation by the release of vasodilator molecules such as nitric oxide. So vasodilator, abrupt rises in vascular resistance are met with endothelial compensation by the release of vasodilator molecules such as nitric oxide. If the increase in arterial pressure persists, the endothelial response is overwhelmed and decompensates, leading to a further rise in pressure and endothelial damage and dysfunction. Alrighty, this is all for part 1 of our hypertensive encephalopathy pheochromocytoma case, and I'll see you all in part 2 inshallah. Please take care, drive well, and don't play with your phone as you drive. Arigatou gozaimasu.